Thank you for joining us today from the PCPCC, bringing you what looks like it's going to be a very interesting presentation on health information technology in the medical home. This is Donna Lickey of Pfizer, and joining me today and helping me moderate this session is Chris Norton, Executive Director of the eHealth Center, and David Mace, Co-Chair of the eHealth Center. Both that center and the Center to Promote Public Payer Implementation are both sponsoring this session today. We're bringing to you today Dr. Aneel Advani, a physician informaticist who's a federal leader in applying health information technology to improve public health and population medicine. Dr. Advani is currently detailed to the Indian Health Service as an Associate Director for Informatics in the Office of Information Technology. His responsibilities include overseeing informatics efforts and executive management at the agency, including the population and medical home health IT portfolio, with efforts in quality improvement and measurement and meaningful use. We're very happy to have Dr. Advani join us today. The presentation is also coordinated with Dr. Howard Hayes, who is commissioned also with 21 years of experience in Indian Health Services and currently is now the Chief Information Officer for the Indian Health Services, overseeing information technology. Unfortunately, he's unable to join the presentation today and sends his regrets, but he's in transit. Just a few pieces of information before we start. We want to make sure that all of you are aware of the technology and begin to use the chat windows on your computers to ask questions. You can ask questions throughout the entire presentation. And Chris and David and myself will ask Dr. Advani those questions as we move through the presentation, but most likely we'll be holding most of them for the end Q&A session. And lastly, I just wanted to remind everyone of the upcoming conference, the 5th Annual Summit for PCPCC. If you haven't already enrolled, you can go on to the PCPCC website and register. The meeting is going to be held October 21st, and it looks like a great lineup of sessions for that meeting. And without further ado, I'd like to introduce Dr. Aneel Advani.
Thanks so much, Donna. Can you just confirm, can everybody hear me reasonably clearly? Okay, great. Good afternoon, I guess, or morning, depending on which time zone you're in. Everybody, and it's a pleasure to be able to talk about an area which is of incredible importance, interest, and excitement here at the Indian Health Service, which is one of the 10 operating divisions of the Department of Health and Human Services, and is actually the main clinical kind of service agency with direct care at HHS. So let's see here now. I think I can do this myself, right? Connected. Go to the next slide here. Great. So this morning I'm sort of going to talk about the Indian Health Service, the context, history, and the population health model. And you know, in that sort of section, really make the point that a lot of the incentives that are now kind of part of the environment for the healthcare system in the United States or in Western countries in general, and specifically because of health reform, are in the same direction that the IHS actually has been facing for over 50 years, if not 100 years. So actually, this is the time really for the Indian Health Service to show the way in many ways for the way a health system can function under health reform. And so actually it's great to be able to sort of present that at this point in time. And then I'll describe a little bit about our Improving Patient Care program, which is sort of the internal name for our patient medical home deployment here at IHS. And then I'll go on at the level of screenshots to describe some of our health information technology efforts to facilitate the patient-centered medical home and population health in general. And then we can have a discussion. So that's sort of the agenda, and it's basically, I think, a third between those sections. So, so to start with, really, this is one of our sort of obligatory introduction slides, but it sort of actually has a lot of information that gives you a very quick snapshot of what the IHS is about. We are a national health system within the federal government that is there to serve the American Indian and Alaskan Native population by treaty obligation, actually, in return for sort of 2 centuries of treaties between the sort of independent governments of the tribal governments that retain sovereignty through treaties with the federal United States and its predecessors. And so in return for, as part of those treaty obligations, the U.S. government enjoins a trust obligation to provide health care and protection of the persons of American Indians and Alaskan Natives. And so there's a lot of implications of that sort of legally and in terms of the framework of government-to-government relations, which we won't go into, but it sort of starts at sort of a level of mandate that is sort of at the very core of our republic. So the American Indian Alaskan Native, we sort of refer to that in short as Indian country. It's about 5% of the land area of the United States, and as you can see, because of past policies, there's a footprint in Indian reservations, and you can see that some areas are in fact kind of pan-state type of service areas, and that includes Alaska, areas of Arizona, and the Oklahoma area, where the proximity to reservations isn't as much of a limitation, and as long as you're in the state, actually there's sort of enough of a footprint to access all services. And then on the reservation side, you can see the Navajo Reservation, sort of very, very large area, the Four Corners area of the United States, which is as big as sort of many states. And then in the East Coast, as you can see, because of territorial expansion, there's sort of smaller footprints and a retention of on-the-ground access to clinical services, even in that part of the United States. So let's see, then we'll move on to the next slide here. In order to really understand IHS, one has to sort of remember the roots of this relationship, and sort of I call that the continental geocultural history of American Indians and Alaskan Natives. And it's probably the shortest way to encapsulate 250 years is just to look at sort of title names of the U.S. agencies that had engagement with American Indians and Alaskan Natives over the last 150 years or so, and you can kind of quickly get a sense of the history. And so in the 19th century, actually, the engagement came under the auspices of the Department of War. And then around the turn of this century, 1910 or so, it became the Bureau of Indian Affairs as part of the Department of Interior, which used to be called the Department of War. And then in the 1950s, because of sort of additional push to really improve health outcomes, the Health Bureau, as part of the Bureau of Indian Affairs, was transferred to the Public Health Service, and then called the sort of Indian Health Service as a component of the Public Health Service throughout, starting in the 1950s. And then about 20 years ago, the Public Health Service sort of reformed, became more of a staffing component of HHS, and IHS became a operating component of the Department of Health and Human Services, currently led by our director, Dr. Yvette Rubido. And then again in the 1970s, there was a very important change in policy from service through the Public Health Service to program goal of tribal self-governance with government-to-government relationships and where we, in consultation with the tribes, sort of look at the responsibilities and functions, and the tribes sort of assign those back to us in the federal sector that they are within their treaty rights to adopt themselves. So in a sense, we now are very sensitive to our tribal customers, actually, as an agency. So in some sense, IHS is like a private healthcare system in the sense that, we have constituents, and we really have to, although we're kind of underwritten by appropriations from Congress, those roles that we play include being a sort of multi-state healthcare system. And so let me go on to the next slide here. And so actually, before I describe the healthcare system, the important point here from this historical perspective is, in fact, there's always been a context of incredibly low resources. So the federal government spends less per capita on Native American health care than on any other group for which it has responsibility, including Medicaid recipients, prisoners, veterans, and military personnel. And so actually, in some sense, the IHS has been forced to do a lot with very little for many, many years. And I will be showing you in a few slides the sort of effect of that, the challenges that we face, and the sort of organizational and philosophical perspective of our health system. But before I go into that, the footprint for us in terms of the American Indian Alaskan Native population in Indian country is, now this is from 6 years ago, it's about 1.5 to 2 million active users. We call that our user population, which is basically the denominators in our national data warehouse. And so those are people who have active medical records and actually seek care on a periodic basis. And that's about half of the total sort of census count version of American Indian Alaskan Native citizens in our country. So it doesn't serve sort of everybody, especially those who are sort of veterans and are able to afford private health care in the more urbanized areas and have assimilated. Our footprint tends to be around sort of the core areas of this regional population here. Okay, so here's a slide on service growth. So a part of this is measurement bias because of the way the census now allows you to self-identify your sort of sub-ethnic components and multiple ethnicities. But a sort of legitimate component of this is actual true population growth. And so, we actually have experienced quite a high growth rate compared to the rest of the country at the level of sort of the average, so about 1.8% per year. We have health indicators and social indicators, as you can see, that provide us with challenges and need to be understood in the sort of historical context of the relationship between Indian country and the rest of the United States. Okay, so let's see here. So I was talking to you about the Indian Self-Determination Act. And so it's a complicated relationship. Doing health IT with this population is a complex exercise because we have jurisdictional issues, we have negotiations, consultations, there's division of responsibilities, and we at IHS have many hats that you might find that we wear that sort of are there for sort of multiple different entities in the private sector. So we are a clinical service entity. We have hospitals, federal hospitals, health centers, health stations. We are a staffing agency. We are a payer. We contract out care more for specialist care. We are a regulatory agency. We develop clinical policies. We're a public health agency. We actually have a national level sort of public health presence and organization that deals with public health. we are a reporting agency. And so actually, you know, under health reform, where you have accountable care organizations that are risk-bearing entities and reporting entities and regulatory entities, actually, IHS has sort of been there, done that for about 40 years. And so you'll see what that implies for how we organize our care model, how we develop HIT, what the HIT is that we have, and the relationship between all three of those. And then superimposed on that is this tribal self-determination, government-to-government, and a division of responsibilities. So let's see here. So I talked about challenges. So here's a slide which is data from 1997, but basically is not too different from what you would see in 2010 in terms of relative risk. So this is Alaskan Indian American Native mortality versus all races in the U.S. So you can see, you know, accidents, diseases of the young, diseases of lack of physical infrastructure at the reservations, and then special elements of disease burden related to behavior and other determinants of health that translate into end result disease burden here. So, you know, diabetes, heart disease are actually both higher, and diabetes especially. Cancer, sort of disease of longevity, are transitioning now with a demographic transition that is taking place in Indian country to more closely approximate that which you see in the general U.S. population. But the demographic transition is sort of starting now, and over the next 20 years, you know, geriatric medicine will start becoming much more important. But because of this, we actually have a separate diabetes program, separately appropriated by Congress. So let me go on to the next slide here, and so I didn't lose the. Oh, okay, so so challenges with this. So, you know, access to care, expectations of the community, socioeconomic status, literacy, access to information, geography. Tremendous implications for broadband access, the way we architect our entire national footprint of HIT, you know, compared to the way, let's say, the VA does it. Transportation to an actual clinic visit can take many hours, and that changes what you encapsulate in an actual visit and the model of care. Substance abuse, you know, behavioral issues, historical alcoholism, and then this idea of, you know, environmental accidents, etc. So that means the IHS consciously in the 50s, as part of the public health service, when in the sort of last decade in which public health, regional health officers, and clinical medicine from the public sector predated the rise of the Great Society programs and really were the engines of community health. We retained that as a model from the 1950s, which the Public Health Service lost, starting with you know, the rise of federal insurance. And so we have a very broad picture of health, and really it's the entire community that is the patient. And that comes across in terms of the way the agency is organized, and the elements of care that we integrate very directly. So, which includes, you know, personal individual health care, family health, public health, population health, this idea of self-governance, the implications for the kind of data and how we can cross-map data, sharing of demographics, the government-to-government implications for measuring different denominators across tribes, lack of consultation required to share information from one tribe to a national aggregate that can be, you know, fed back to sister tribes. Environmental data, and you know, at IHS there's a whole division of environmental health, and you know, we're still building up basic infrastructure for in collaboration with the Bureau of Indian Affairs for our for the tribes. And so it's the broad national kind of view of healthcare, and some of the elements of health reform actually kind of are targeting that picture now with a pendulum swinging back. So I have a few slides to sort of illustrate how that takes place and the conceptual justification for treating the population as a patient. And I used to be at the CDC before coming to IHS, and so this is sort of an important perspective that I find to my delight is actually still part of our healthcare system here. So here's the trend in diabetes burden between the general population and American Indian and Alaskan Native. So you can see actually it's not a problem that's going away, it's actually a problem that's getting more acute. I don't think this is age adjusted, but I think it's still sort of very valid. Oh, it was age adjusted, so it's actually a very real signal here, you think. So here's a slide from a paper in JAMA by Greg and Albright, who are part of the Division of Diabetes Translation at CDC in 2009. And what you see here is based on sort of National Diabetes Surveillance System, which actually does not have row-level data. It's reports from the states up to the CDC in sort of the traditional national surveillance model. And what you see here is in column A, there's a trend of end-stage sequelae of diabetes in persons with diagnosed diabetes in the denominator. So you can see here, for those people who have diagnosed diabetes, actually, amputation is going down, end-stage renal disease is going down. So our trials for, tightly controlling diabetes over the last, this is 15 years from 1990 to 2005, when close management of diabetes was sort of the signal mechanism for control, is actually very successful, as well as including mortality from hypoglycemia, from hyperglycemia. But if you look at the total population, you saw that increase in the American Indian population. There was a slight upward trend in the U.S. population as well. If you look there and you look at the same sequelae, actually, you do have a decrease in mortality, but the sequelae and the disease burden, it's not really in the same direction. End-stage renal disease is going up, and amputations are, they've gone up and then back down a bit, but they're still sort of, they're not below where we used to be. And so what's the difference between those two pictures? And the difference is, in one case, in A, you're plotting people who have already been diagnosed, so you're really talking about tertiary treatment and secondary prevention. Whereas in B, you're talking about the sort of general prevalence, which includes increase in your denominator. So if the number of people with diabetes have been going up, actually the absolute risk from all these sequelae are also going up. So there's sort of two different pictures of the difference between the perspective of a health system that treats the community as a patient versus the perspective that treats an individual as a patient. In one case, you may be very successful, but you're actually sort of not that successful, and you still have a very sick community out there. And that's really the perspective difference between a sort of national healthcare system and your individual clinical physician. So just to sort of bear home that point a little bit more with 3 or 4 more slides. And what are the implications of that idea of denominator? So one of the implications is, behavior matters. And so you can see the sort of similar relative risk, age-adjusted relative risk data from 15 years later, 1997 to 2003, which actually this is the most recent published data that I can quote. We're preparing the 2010 version of this. And so you see, TB, chronic liver disease, diabetes, there are still risks. This isn't absolute prevalence, or absolute incidence. It's relative risk, so it's not the same slide as the sort of order of mortality. But you can see the behavioral diseases and environmental diseases are still very important, and obviously chronic liver disease and cirrhosis is related to alcoholism. Okay, so here's another perspective. So this is from PLOS Medicine, a study by Izzati, and it's contributory all-cause mortality at 2 different time intervals. So it's basically plotting for each age group, male and female, the different relative risks and changes in the probability of death from periods before with respect to sort of different types of conditions. So basically, how do we die at different age groups? And you can see from the top row to the bottom row, the colors are changing. The components of those bars here are actually made up of different diseases between the period of 1961 to 83 and the changes that took place in 1983 to 1999. So it's really a change in the rate of growth. And so you can kind of see the change of the behavior of our disease burden in different segments of the population, ages and sexes. And what you see here is, this makes the point that we are all mortal, we all die, but as a community, the community changes the sicknesses from which it suffers. And so even though we may be sort of very successful for an individual person to compress their morbidity, which you can sort of see here as well over the sort of difference in the 2 15-year periods, even though we might be successful with particular individuals, the denominators are non-monotonic. So it's not just all, a good story in one direction when you use the community as a denominator. There's always going to be national level challenges. Medicine will always be necessary, and so really the sort of chameleon-like behavior of a community when you sort of have a national healthcare system, continues to produce challenges from the point of view of evolving your clinical model. And so this is the sort of point to make here. And I thought this slide sort of just encapsulates that story, with some real data very, very well. Okay, so let's change gears a little bit, I think. So, and I may have made these points already, and I don't know why I've got this animated, but and so when we think about denominators, I talked about that sort of prevention-oriented aspect of them. I talked about behavioral change, sociocultural context, and equity. And so really, health information technology for system change is really what drives the reason you have HIT for a national healthcare system. And you need that system change constantly because the community changes as a sort of chameleon-like story, or amoeba-like story throughout history. So population health informatics is a sort of key driver. And so the elements of the medical home, the elements of sort of new accountable care models, and population health are really sort of joined at the hip because of this sort of set of conceptual points that I just made. And a lot of time, even at ONC and our meaningful use regulations, sort of communicating that to the interlocutors on the policy committees, the standards committees, who have that sort of bread and butter daily practice by people who select systems at the hospital enterprise level and really drive the HIT market for private sector vendors and suppliers. It's actually hard to communicate how important this aspect of health IT is when the entire conversation is just about care transitions from one doctor to the next and not taking that global picture. So I enjoy the sort of opportunity to sort of make this point because it really is so key. And as we move forward into health reform, that perspective on health IT or health informatics will become more and more important. Okay. So let's change. So I've got another sort of slide on this. I think I've made this point. Let's change gears a little bit and talk about population health informatics and the elements of it, and then I'll talk about our actual medical home program, and then sort of talk about the relationship between the two in the third part of the talk. So we have a sort of full service, population health IT program here at IHS, starting with the sort of top of the queen of the segments here, which is to improve our quality, and then going on systems to measure clinical and performance reporting, make conclusions from this reporting in terms of clinical repositories for healthcare effectiveness and research, and then from that develop clinical policy for care management in a systematic way to actually intervene at the point of care, and then epidemiology and surveillance to look at the outcomes of care and the sort of environmental components of those interventions that go along with those interventions, and then feed that back into inferences about quality improvement. And then sort of in the center is this idea of meaningful use of health IT, which actually, if you look at this picture and look at sort of the components of MU, you will see a lot of stage 3 in here. You will see the learning healthcare system. You will not see as much directly about stage 1. So actually, you know, what IHS has envisioned is already, and I'm sure a lot of your organizations, to really drive healthcare model change, which is really what the patient-centered medical home kind of impetus is about. You're really looking at stage 2 and 3, if not stage 3. So the story is yet to be told on MU for the purposes of PCMH, and I think that will come out in the rest of the talk. All right, so let's talk a little bit and describe a little bit about our Improving Patient Care program, which is our medical home program. So let me start with the with the sort of priorities that our director of our agency has challenged us with at the agency to renew and strengthen our partnership with tribes, to bring reform to the Indian Health Service, to improve the quality and access to care, and to ensure that our work is transparent, accountable, fair, and inclusive. So I think this is supposed to be circling the quality of access to care button rather than reform, but actually it works both ways. So the Improving Patient Care program, the aim is to change and improve the Indian health system. The IPC will develop high-performing and innovative healthcare teams to improve the quality and access to care. So this is sort of the encapsulated mission statement for the Improving Patient Care program. And I have to acknowledge the next few slides in this section are borrowed or incorporated with the help of Dr. Lyle Ignace, who is a program director of our national IPC program team. Okay, so about 4 years ago, about 5 years ago, we started with IPC sort of 1.0, so to speak, version 1 of this program. And this program has been developed in close coordination with the Institute for Healthcare Improvement, which is the institute at Harvard that Don Berwick, who is now the CMS or acting CMS administrator, previously started and led. And so actually, ironically, here's another instance where IHS was sort of looking far ahead and got a head start on a lot of the sort of initiatives that and the sort of philosophical underpinnings of the changes that are now coming out of regulations out of CMS. And so this is sort of, you know, we had sort of 14 initial sites. Our usual early adopters for HIT overlapped with these sites very nicely. But it was sort of spread through different categories. So you can see IPC1 was mostly federal sites, but incorporated some of the other tribal and urban sites as well. And then in 2008, so we had IPC2. This was 38 sites, and you can see that they've increased. And this involved sort of a actual evaluation. The spin on sort of this part of the medical home kind of improvement was not as much the chronic care model per se, but just sort of general systems improvement and quality of care change. So we just tried to go whole hog, system-wide, and do everything at once rather than one change at a time. So this is not pay for performance. This is not, you know, specific vertically integrated quality improvement for specific vertical lines of service. You know, so this is not the 90s. This is really the late 2000s. But it was sort of pan service change, and because of the successes, plus because of sort of tremendous ambitions, you know, after a couple of years of this, you know, we really at the agency we had to decide whether we were kind of going to go the whole hog, make this our national clinical model, or just you know, move on. And so there was sort of an inflection point a couple of years ago, and we reinvigorated our leadership. We reinvigorated the engagement of the new sort of director and administration, and now we actually are sort of fully engaged with a chronic care model medical home underpinning to this system-wide improvement program. And so now we have over 68 sites in the sort of main part of the program, and we're basically adding 100 sites in the next 2 years. And just to give you a sense, we have about 465 different physical sites at IHS. We have about 565 or 564 federally recognized tribes, in addition to the state tribes and unrecognized tribes. And then out of those 565, there's sort of 465 physical installations, and then out of those, there's about 265 or 235 different physical deployments of our PMS HIT system. So physical separate servers that have their own medical ID numbers, and so in a sense, we're really a national health system with sort of multiple interrelated subcomponents that are sort of individually operated and run, have their own sort of personal relationships with the tribes that they service, and so to add basically 170 to 200 the next 2 years, it's basically the sort of national medical model rollout for the entire healthcare system. And so that compares to about sort of 550 sort of community health networks or federally qualified community health centers for HRSA. So you're talking national level numbers here. Okay, so what do the sites do through this sort of model? There's sort of major activities at each site include learning sessions, training, impanelment of patients, the identification of leads for each quality goal, and then a rapid cyclical improvement methodology. So there's lots of communication, knowledge support, knowledge portal learning, skills development, and so here's sort of I think there's another 4 arrows here. So we've got sort of a foundation series, collaborative, that's sort of our closed set of tasks to collaborate out to the field. There's a learning network of more advanced early adopter subcomponents of this that are rapid innovators. There's the instructor support team, and then there's sort of national team and an evaluation team evaluating all of these that I'm sort of involved with directly. Okay, so all right. So the model for improvement is the sort of plan, do, study, act cycle that is sort of a generic term. And so, this is sort of implemented at each site, which we call a microsystem. And, sites can be 1 or 2 doctor clinics, 2 tertiary care hospitals, but mostly are, about 5 clinicians or so would be the sort of average that you see. So that's sort of the picture around taking, professional local responsibility for quality improvement. Okay. So the actual content of the changes and the sort of substantive model underpinning the program elements of this is based on the chronic care model from Wagner and adopted by ACP and ASIM in 2003. So it's sort of very close to underpinning the same models in the medical home, or the initial sort of model of the medical home, and that involves all of these elements here, which is healthcare organization, create a culture and organizational mechanisms that provide safe, high-quality care, community resources, self-management support, delivery system design, decision support, and clinical information systems, all there to sort of improve quality. So, this is sort of generic outline of the chronic care model. And so, we have a change package that we create, a sort of tool set that involves documentation, training, a sort of replicable engagement at the site level, as well as the infrastructure creation and the data reporting. So So what do we measure? The sort of outcomes and the indicators we're using for this sort of rapid innovative cyclic improvement include some Government Performance Reporting Act type of clinical measures that the agency is held accountable for, chronic condition outcomes. You know, a lot of this is friendly to the clinical quality measures in MU, and probably for the next year and as we converge on our quality reporting systems, will involve very closely the quality measures as part of stage 2 and 3. Access to care, patient experience, as well as data on cost and efficiency here. And you know, we've got some goals that are not necessarily meaningful in an absolute sense here in terms of describing them, but are sort of important in terms of the embedded nature of this with our numbers in our sort of healthcare system in general. So I do have 2 slides here of completely anonymous data here, just to illustrate the point that give you a sense of the sort of size of our sites and then sort of how we kind of do this process. So here's sort of a colorectal cancer screening. So here's a microsystem A, which is really means, you know, site. And the blue line is sort of the denominator, and you can kind of read the number of patients on the right side here. So this is about 225 patients in that clinic, and the sort of abscissa here is years. So each of these is kind of a quarter. So you can kind of see this is over about 3 years, about 3 years of reporting. And so you can see that, you know, after 2008, when IPC2 started or IPC1 started, you can see there's sort of a rapid improvement of colorectal cancer screening, and this is true for, you know, a lot of the measures. Now it's still not 100%. There's still a goal that we're reaching. You know, 70%. We put that in there. It should be pretty high for, you know, the appropriate patient population. So the denominator includes sort of the appropriate patient population here, and you can see there is sort of, you know, sustainable change. And this sort of PDSA cycle actually works for that reasonably long list of measures. And so in some sense, this data, and you can see, you know, so here's another site which sort of started above the threshold already, and, you know, in contrast to a sort of national benchmarking type of quality improvement where there's sort of just some external pay-for-performance kind of cutoff, because this is sort of internalized local quality improvement PDSA cycles, you can see that it's continuing to improve over time, even when it's past the actual national threshold. Now here, the sort of denominator is 400 patients, but, you know, still basically a microsystem. You know, this is basically does recapitulate the sort of RAND results and studies that evaluated the chronic care model. It's actually quite difficult for us to, I mean, it's a nice challenge for us to evaluate our success and kind of develop methodologies for evaluation that can inform our program design when you have such a moving target as a denominator that's improving all the time, and have to evaluate the elements of rapid cycle improvement and sort of nationally aggregate those, you know, with limitations of data sharing, whether you have row-level data or not, that's sort of cross-linked. So it's actually a lot of interesting, from the informatics point of view, in addition to the HIT point of view, lots of interesting methodological issues here to work with an actively functioning medical home program and kind of really use it in real time to improve care and change your clinical model and point ways to improve your infrastructure. So this slide kind of illustrates that idea, and I'm just going to try and go through the, I think this is the end of the segments here. So the point here is, you know, you really need a lot of data to do this rapid cycle improvement, data at the local level that's understandable by clinicians, that gives them a sort of population perspective on their own 400 patients, data for the national health system that gives a sort of real-time, you know, reasonably real-time, not once a year, but quarter-by-quarter level, you know, monitoring as well as goal setting and analytic capability. And so data is really the fuel for quality improvement. And those of you who have, you know, actively run either HIT infrastructure for quality or medical directors and have run sort of quality improvement itself this will click with you right away. It's been, as a sort of quality informatics type of lead here, it's been great to actually see that that message, jumps out at everybody as soon as they sort of really dive in and are part of the program. It's great to sort of see the light bulbs going on, and but then when the light bulbs do go on, you just sort of really realize how much of a challenge the data infrastructure and data analytics problem really is. And so that's the other sort of general point to make here about patient-centered medical home is, because this is sort of systems change adopted at all levels of the healthcare system, you actually need analytics and analytic support not only at the enterprise level, not only at the sort of national surveillance level, but also at the point of care level. And the informatics and the health IT strategic approaches to enabling uniform, heterogeneous data-based analytics in real time, as well as to support, close program design, with a sub-year kind of level of improvement, is really challenging and has not really made it into the sort of strategic perspective of health IT policy just yet. I mean, it may be coming very soon, but that idea that you have this sort of flow of analytics sort of throughout the chain here is really a message that needs to be talked about. So I'm kind of evincing my population health bias again. Okay, so let's change gears, and I don't know if do we want to stop for questions here or just sort of motor on and then do the discussion after the next bit.
Dr. Advani, there's that one question that has come in on a previous slide, and that's what is your current 2011 population size for the American Indian and Alaskan Native population?
It's about 1.8 million. Okay. It's not over 2 yet. And of course, it depends on, we have a lifetime medical record from, people's birth to their death. So, if people move away, they're still active. They can still come to the reservation for care. So, how you measure, what the actual footprint of the population is there's no right answer. It's an estimate, a statistical estimate, outside of even the sort of duplicate record kind of level of error bounds, just in terms of the real service burden. And then, as programs for financing healthcare and access to different state-based and federal programs for healthcare and health service change that Native Americans have access to, we, by a Supreme Court decision, actually are a payer of last resort. So actually about half of our resources, although they're appropriate and come from public sector, are actually transaction-based, just like any healthcare system would. They would bill Medicaid, and so the relationship between the access to active transaction-based programs that you, as a Native American, can bill because you got registered under Medicaid when you never bothered before, or because your clinic kind of did that for you this year and they didn't do it for you 10 years ago. All of those events kind of change what and how you use the actual facility. And so the denominator that is just in the clinical database doesn't necessarily directly convert into the sort of picture of clinical activity. So it's not an easy question to answer. But the bottom line is, if you want to equilibrate it from that 1.4 million, it's basically gone up to 1.8.
Okay, great. Another quick question: what are some of the key differences between IHS hospitals and the tribal hospitals?
Well, in some sense, not that much, because a lot of the changes that took place in the 70s were, based on tribes sort of taking ownership of some of the IHS infrastructure. The main differences, I would say, is that there is a variation in wealth amongst different tribes depending on their economic activity, and so there are some tribes that are sort of able to provide really state-of-the-art, beautiful facilities and very substantial specialty care that involves some amount of provision of care that they have kind of delegated or employed from IHS federal staff physicians, being employed in the tribal sector, but then also access to private, either federally qualified health centers, community services, or just, locums or per part-time specialty care. And so it really does vary. But your average, out of those 44 hospitals that we had, your average IHS hospital, whether it's tribal or federal, is going to be a 5-bed hospital, very much like what you would imagine exists in rural America. And so the easiest way to picture the sort of footprint and the healthcare system at IHS is it's your rural healthcare system equivalent. And so that's sort of the bottom line sort of answer to that question.
Great, thanks. I think we'll probably hold the rest of the questions till the end of the presentation. Just want to remind all the audience that if you do have questions, do go over to the drop-down box on the right and submit your question there, and then we'll present them to Dr. Advani at the conclusion. And coming up about on the hour, Dr. Advani, for time check.
Okay, great. So I do have some screenshots, and I think these will be quite fast. So the IHS medical record system is called the Resource and Patient Management System, which actually is a fork from CPRS. We have our own EHR GUI that's like VISTA but different, but the MUMPS sort of modules are sort of joined at the hip with the sort of infrastructure and substructure around the VA. So we really do depend on the Veterans Administration system, and increasingly on in the future on this integrated EHR being developed. So there's a portion of the RPMS system for population health that we call iCare. We've had health information systems for 40 years. We've had this sort of population community health focus as part of the health information systems that we've had for 40 years. But it was around 1984 that we kind of adopted the sort of VA CPRS infrastructure and forked from that. And our EHR sort of GUI solution is about 5 years old or more. And then iCare also started around that time, and that's our population health management application, which is what I'm sort of focusing on here. So this is the old legacy interface, looks a lot like CPRS used to. And then this is sort of the new one, just looks like a medical record system. Now, we are a small agency. We have a reasonably small IT budget, and we have developed our own EHR that's sort of open source. You can kind of FOIA it. We're working on the sort of framework of sharing by official open source. We have a number of entities like Hawaii, West Virginia Community Health that have actually adopted RPMS as a medical record system out there outside of the federal government. So it actually does work. People have reused it. And we have certified this, and we were the first federal healthcare system and EMR to be certified for both ambulatory and inpatient as of April of this year. So we're on the sort of meaningful use train here in one of the earlier compartments. So what's unique, I think, about RPMS, especially when you compare to the same code base at the VA, is we actually do local clinical repositories. So, this is still MUMPS-based. It's still hierarchical file systems, hierarchical databases like MUMPS is. But we have sort of redundant local analytical repositories at each site. And that's called the patient care component. So we take our encounters and our patients, and we use that information to create files in the patient care component. And then we run a ton of analytics on top of that. And so the population health applications kind of, from care management for women's health or immunizations or our public health applications kind of run from that. And so I've kind of done this. So I'm going to basically talk about a couple of elements of this today in terms of the demonstration, quality of improvement, care management. I've exercised on epidemiology and stuff, but we won't talk about all our other population health work here. So the main components of population health applications in RPMS that I'll describe are sort of the components of iCare, some of the functionality. There's a lot more that I won't have time to go into, and we actually just Google it. We've done various presentations. You can always find out more, and we're very happy to give demonstrations to organizations from our eye care team here. I'll talk a little bit about clinical reporting, and I won't actually go into our H1N1 and epidemiology surveillance or our workflow-based sort of proto-decision support immunizations or clinical repository comparative effectiveness work. So here's eye care. It's sort of part of the GUI for our PMS. It's sort of a separate trigger to start it, but it's fully linked. And the idea of eye care is to link the information from individual records while you're in the clinic to community information, to panel information about populations of patients that either directly apply to you, that apply to your quality improvement activities, that apply to your public health activities, that apply to the analytic inputs to decision support and to denominators. So this is sort of what it looks like. I sort of mentioned this already. So it's an interesting, unique model. On the ground, daily incorporation of panel-based reasoning and population health as part of the bread and butter part of the health system. I have not seen that in the private sector as much, and maybe now because of accountable care in medical homes, all of that will start happening. I know, for instance, at Geisinger and a lot of the sort of HIT applications like iCare, for local quality reporting and tracking, those have been developed and actually mostly on the top of your COTS kind of EHR product. But in terms of sort of a true integration in practice, this is still somewhat unique. I mean, maybe in 5 years, the word will get out. But so how does this relate? So it's sort of, built on top of the sort of local repository connected to the EHR. And then now, so the elements of the patient-centered medical home and how that sort of maps onto eye care. So just to review, and I'm sure you all have sort of thought about this deeply for a few years at least. These are sort of, I think this is the ACIP set of principles that were adopted for patient-centered medical home, probably by this organization itself, right? So enhance access and continuity, identify and manage patient populations, plan and manage care, provide self-care support and community resources, track and coordinate care, measure and improve performance. So a lot of these principles are sort of very directly sort of implemented in multiple ways and are, really already naturally part of the healthcare practice and HIT system for the sort of reasons I've outlined before. Today, I think I've got a couple of slides that sort of illustrate our measure and improve performance improvement and then the track and coordinate care sort of panel definition kind of functionality. So I think we're about to go into more sort of specific screenshots, but that's sort of, there's sort of other applications that would apply to registries and things. Community health representatives, non-traditional determinants of care, kind of data flows, risk factors, all those things are behavioral health. These are all sort of parts of our HIT infrastructure. Okay, so, oh wow, okay. So this is from the National Priorities Partnership, and it just sort of shows you a framework for performance measurement. So before we sort of focus down on elements of functionality for quality reporting, here's another justification for the connection between daily clinical care and this idea of population management. Now, the idea of risk adjusted health measures, and the connection between perceptions of quality reporting at the national level and the sort of case-specific reasoning that physicians or clinicians practice for an individual patient. That's the other side of that, full circle, and that itself actually getting that message across for a different purpose as a different policy imperative at the federal level is also sort of work to be done. And so it does come out actually when you're building HIT systems and trying to design kind of what is the message about the national health measures or even the IPC measures that are sort of part of the measurement and part of the evaluation as part of your PDSA cycle. If you have a different case mix in your microsystem with your 400 patients, you're going to see completely different numbers. And you're going to be acting with diagnoses and treatments that may not map to the full goal. And so it's sort of like no child left behind issues. When everybody tries to go for 100%, it's just not going to work. The case mix adjustment has sort of similar issues in healthcare. Okay, so let's see here. There's some arrows. So we have a number of different quality measure reporting programs that we need to service as a federal entity, as a sort of clinical delivery entity, as a regulatory entity, and for our own internal purposes. And so, there's accountable care organization measures, there's MU measures, there's measures for value-based purchasing, our government performance reporting measures that are clinical oriented, our HRSA, community health, UDS measures, and then these IPC measures as part of our quality improvement program. There's actually a number of other systems. So we have to kind of support all of those. There's separate appropriated programs in diabetes and cardiovascular disease, HIV care that are all sort of part of our quality measurement framework. And so we have iCare, which is sort of local level analytics. And now we could sort of expand this to national views in your traditional enterprise or system-wide business intelligence framework. We have a separate sort of data warehousing clinical repository evolution effort there. But this level, this sort of analytics at the sort of local microsystem, which actually I really like as a formulation, because it's not just point of care for individual doctors. It's really clinic level, clinical director level management, and it's not the same as pay for performance and accountable care with sort of tremendous financial implications that are measurable, but is really at the level of clinical, coordinated decision making for your population of patients where you affect the care and you need that perspective in organized medicine. That's the level at which we actually report locally on national measures. And so that's sort of an incredibly important tool to track. And you can see there's sort of a number of different panes here of functionality that we don't have time to go to. There's decision support. There's inferences based on intermediate concept inference called diagnostic tags. A lot of these are sort of pre-compiled in different patches, so we don't necessarily have a sort of on-the-fly kind of concept definition functionality in a lot of places, but it really is, because it's an active HIT program that's closely related to a practicing clinical service agency, we can do quarterly patches where we actually have on-the-ground implementation of clinical policy, and we can do it inexpensively because we don't have to design it in a sort of vendor-customer relationship. We're doing in-house development, and that's a huge, huge point as well. I mean, the whole conception of stage 2 and stage 3 for vendors really begs the question of who's going to take on the responsibility for knowledge management and knowledge creation around the clinical semantics of this decision support. And it's a big hole in the business model of out in the marketplace. To be able to charge per transaction and amortize the cost of maintaining a decision rule, very few vendors, because the clinicians need to actually own that, and the clinicians don't have an in-house relationship unless you're a very, very big vendor with a sort of software as a service model. It's hard to actually absorb that and maintain it over time. Plus, all of medicine is just too huge. So luckily, we actually, our Office of Information Technology reports to our Chief Medical Officer, just like the Office of Clinical and Preventive Services and the Office of Public Health Support. So we actually have a fulcrum from which we can take the benefit of help from clinicians and have measure stewards within the healthcare system who really own the definitions of these things. And we can, at every quarterly release of our population health applications, get their input and then absorb the, and those measure stewards are the leads for, that improvement area. So it's a very nice close collaboration that I think is also another unique part, but it sort of points the way of, what's really necessary and the kinds of organizational initiatives that, maybe PCPCC would have to adopt as this sort of entity that brings healthcare vendors, self-insured, risk bearers, and the clinical community together to kind of really develop that model for how you roll this out, because it's not really solved as a sort of business model issue out in the private sector. So just sort of pontificating a little bit. the main point here is you can drill down from that population view right in the medical record right there. And that's huge as well, because actually, because there's a sort of a clinical repository that's actually a direct reflection from the MUMPS hierarchical database, this is actually really hard to do in relational analytic, feeds nightly from medical record systems in the sort of traditional local decision support model. So in a way, because we take shortcuts, because we don't have as much capital available for developing systems, we allow ourselves interoperability in ways that traditional vendor-based system may not. Although you can do from last night what the drill down would be for that patient. Okay, so track and coordinate care. So another 5 minutes, and then I'll be done for questions. So the important functionality here is, this is to support the medical home. So we have an incredibly robust method to define panels of patients that can then be fed into, we're developing actually group orders to do screening orders all at one time with one button for the whole panel. The proto decision support with workflows and communication reminders for all of these. Reporting capabilities, exporting capabilities, graphing capabilities, but most importantly, kind of taking ownership as a microsystem team for a set of patients where there's a many-to-many relationship, and having the HIT population health application kind of manage that relationship in real time without interrupting the workflow of your EMR with your individual lab results and note-taking updates. That is amazing functionality. I'm just amazed that our team actually is able to do this over the last year, but it's being very well received by the actual care teams involved in the medical home implementation. There's various ways to define. You can do sort of raw queries. You can kind of filter on criteria. You can filter on sort of patient demographics, all of the above, by provider participation, by class of patient designated provider impanelment, formal impanelment. All of that here is possible. You can do pre-canned panel definitions or sort of more ad hoc versions, and then the sort of more limitations of the ad hoc version. So you get the patient level detail. You get core measures sort of across the top here for those. There's sort of provider level detail. So because this is a hierarchical database, there's no on-the-fly data cube kind of thing. It's sort of pre-canned, but it's in a sense, the good thing is because we have to do it pre-canned, we have to constantly communicate about workflows that the care teams really need and match our HIT, wizard-based functionality here, menu functionality, right to the sort of 80-20 very fast requirements that the care teams need. And as a result, the physicians actually use this individually. So it's not, your decision support analyst in the back office. It's sort of at the point of care. So we just sort of play to our strengths a little bit. Again, provider aggregation for quality measures, et cetera. You don't have to sort of, and then facility level aggregation for some of the resources. And then this all gets exported to a web portal. Okay, so just in conclusion then, so this is sort of the 7 or 8 HIT drivers and functions for the patient-centered medical home. And I'm actually looking forward to awaiting the sort of work that the PCPCC did in consultation with ARC on the sort of fuller, sort of more comprehensive list of these elements. Hopefully will come out soon. But clinical decision support registries, team care, care transitions, personal health records. I didn't show you our blue button personal health records. I haven't shown you our telehealth and measurement performance reporting. So we actually do have a lot of these elements already in play at IHS. So what's our sort of, in conclusion, our experience, and just to sort of drive home the main points here of the 4 questions. I talked about the long-standing drivers in the care model for over 40 years and how that we have seen at IHS in our experience and how they're now affecting the general healthcare system. We talked about community as the patients, meaning that population health IT is integral to daily work. We talked about the close collaboration both in terms of our HIT development process as well as sort of programmatically just in terms of our program goals between clinical and national programs for HIT. And in a sense, this is the sort of PDSA model for HIT itself. So it's sort of kind of using that philosophy of PDSA, quick, rapid, innovative cycles for quality improvement, and the idea of agile development and HIT, and they're really the same. They're the same process, you know. And somebody who's interested in quality informatics would sort of see that connection. And then lastly, you know, evaluation and data-based medicine really is an important program, is an important element of not only quality improvement but all HIT deployment. So before I end, just wanted to acknowledge our national RPMS program team, you know, multiple people, our national eye care and population health teams, our national IPC program team, our health and human service collaborators, including the VA, CPR, and most importantly, all the incredibly committed, mission-oriented, hardworking IHS innovators throughout the years. This is really, you know, built on the shoulders of their work. All right.
Great, thank you, Dr. Advani. We have several questions that have come in during the talk, and I also wanted to remind the audience, if you do have additional questions, to go to the drop-down box on the right side panel and enter your questions there, and then we'll present them to Dr. Advani. First question is there a mandate to implement patient-centered medical home across the tribal systems in the same way that you at IHS are driving the model?
It's not a mandate, of course, because the tribes really own their components, but in general, for on-the-ground system-level improvement, the tribes generally participate wholeheartedly. So it definitely includes the tribal sector on all of our efforts.
I don't know what you're looking at.
But is there maybe somebody who needs to mute their line? We're hearing some crosstalk. But in any case, the short answer is there's no mandate, but definitely most of the tribes are participating.
Great, thank you. What is the database technology for the questioner asked PCC database? I wonder if they mean IPC database, but
it's MUMPS. It's just another file system in the hierarchical database of MUMPS.
Okay. Relational database system? Or
no, it's a hierarchical database, so
hierarchy.
It's not relational. It's rooted on, it's got two files rooted on visits and encounters and one rooted on patients. And you sort of rifle through those IDs as a root in order to get at any information. There is some caching which could be, you know, with more modern technology, but that's mostly for the purposes of runtime caching, not to replace the PCC actual clinical repository at the local level. So there is some sort of relational level, but mostly object relational, sort of Java-based, you know, caching kind of techniques. But that's not sort of the primary actual data model for the true local repository.
Great, thank you. Is your iCare system complete, or are you continuing to add new capabilities for?
We're continuing to. So, for instance, I mean, and you know, and we're very happy to collaborate. This is sort of government, you know, public sector work. So the public owns it, but you know, the full service rollout of true active decision support, which can reason fully for full guideline-based care, isn't done yet. We've started with workflows or in communication. The idea of, I mean, the future stuff we're starting with group orders, the decision support, and the understanding how much is necessary of inference at the local level to validate a group order for ordering screening for 100 patients. Tracking, you know, with one button. So basically managing the population truly as a patient with analytics in an interventional way using HIT is all work to be done. Cross-mapping real-time transactional versus, you know, health exchange standards compatible C32s into the conceptual subcomponents of reasoning and reporting on population health, quality measurement, cross-mapping the semantics between quality measurements, updating all of this for ICD-10, you know, coming up with a common data model across quality measurement federally. These are all, you know, and then actually elevating the CRS user interface analytic capability to have a true data model specification that is independent of the MUMPS RPMS code base and repository, so we can kind of apply it to our COTS partners at some of the tribes. Those are all things that we need to continue to work on.
Great, thank you. Is the Indian Health Service connecting to health information exchanges? And if so, is clinical data from health information exchange is slated to be incorporated into your core measurement data?
Yes, it is, and thank you for that question. So we are the sort of prime internal federal entity that implements everything that ONC comes out with, really. So we have, and because we're actually a national health system with, we're a system of systems, and so all of the policies that are national level policies, we can actually, they actually legitimately apply to us, and we sincerely try and implement them. So we do have a HIE between, for instance, for the use case of a tribal member going from one clinical installation, probably not across tribes, but to an urban program, or between two locations that have independent EHRs. We have a master patient index implementation that would sort of connect IDs across tribes, and we do have a C32 CCP-based health summary. We are creating a national clinical repository based on health exchange summary level data, and we're doing a quality measurement use case on that. So that's actually kind of a first. It's sort of similar to the Query Health kind of initiative that's coming out to actually validate whether that use case would work. I mean, the Q105, the C105 work kind of is in pause mode for the quality reporting data specification that came out of HIPSP for a couple of years now. So, we're busy kind of implementing the whole HIE philosophy.
Great, thanks. What strategies or specific tactics are being contemplated or implemented to engage patients directly with the care teams and the iCare population health platform?
Can you repeat that again?
Yeah, what strategies or tactics are you contemplating or implementing to directly engage patients with your care teams and the iCare population health platform?
So I think the key question there is how to engage patients in this sort of three-legged relationship. That's a great question. The sort of patient perspective on the medical home improvement, it's really a core part of our mission and our goal for why we've created this program. The methodological and program design elements to truly improve the patient experience through the sort of, internal provider system change churn and the HIT healthcare infrastructure churn that you've seen on all these slides. I have not really outlined, but I didn't really include those in my backup slides, so I apologize. But apart from the fact that that your data sort of as a patient just does get into the system, and so somebody's doing some good things with it, we do have sort of specific outcomes, and if I rifled back through those to one element of that measurement, there is sort of patient-centered measurement around wait times and sort of things that directly affect patient access and the patient experience, and so that there was actually sort of 4 quality measures that I showed you in that IPC measurement, and so those are sort of the very direct patient-centered kind of goals, and maybe I didn't sort of read down low enough on that slide to emphasize that point. So, so we do have that, but the sort of how you sort of kind of really translate that into on-the-ground systems change with the patient really front and center, outside of the fact that there's sort of common information flows, like in the patient-centered medical home health IT infrastructure point of view, which sort of self-evident for all of us here. It's a great question, and there's still lots of work to be done.
Great, well, thank you. Well, Dr. Advani, on behalf of both the PCC Center for Public Payer Implementation and the Center for eHealth, I'd like to thank you very much for your very interesting and informative view of the complexities and challenges of population health management in one of our national healthcare systems. It's very well appreciated and received, and also like to thank our audience who's been in attendance through the hour and a half of the presentation, and you've got a great job ahead, and really want to thank you for taking the time to be with us today.
It was my pleasure, and we're always open to talk to anyone who contacts us, so please don't hesitate.
Great. Would you like to make your email address available publicly for further questions, or how would you like to handle that?
So it's aneel.advani@ihs.gov, and you probably get that from Google, but you're welcome to sort of distribute that.
Okay, great, thank you. And would like to put in a final plug for the October 21st PCPCC Summit in Washington, D.C. You can register online, and pay now or pay more later, I guess, or the watchword on that. But hopefully you'll be able to join us in October for what appears to be another great session with your peers. So at this point, I'd like to close the session and thank you all for being in attendance.